all right? And we are gonna stay below iliac crest, I know. There you go, to make it weird, okay? So to make sure that we find iliac crest and we know where that is, we are going to mark out where her iliac crest is. And I'm gonna draw that out, okay? So I'm gonna stay below iliac crest, right? I don't wanna come up here, right? We're good with that, okay? Yeah. Found iliac crest. Okay, so we've got my TFL that we're gonna needle. Okay, so if I'm kind of feeling like in through here, go ahead and bring your knee up like a clamshell. There you go. Good use of directions. Teasing you. Okay, do that one more time. Okay, so I've got TFL. Right. So once I find that, so I can do a couple of things. I can make an X. Right. Now, if I make an X, do not put the needle through the marker. As much as she'd love to be tattooed, right? And I'm sure that these are, you know, they're low odor, but they're probably quite toxic, okay? I don't know. So don't like, don't go through the marker. So go next to the marker. What I usually tend to do is make like a circle, right? So I'll go right in my circle. Or if you don't like any of those, I've got these handy dandy little reinforcement tabs. Amazon thinks that I just have a rough day with my binders, and you can go like that and put your needle through there. I don't really care, okay? But just don't tattoo your person. I have people in class are like, I thought you said to go through the marker. I'm like, what, why? Right, go ahead and lift leg up there, hold that for me. Pretty good, okay? Right, so glute med's a big honking muscle. Yeah, I know, right? So I can go back through there. Great for glute med. Certainly if her pathology is a little closer to like the greater trochanter there, I can come a little bit closer to that, right? To the TFL, we've got glute med. I can come middle of the IT band. Again, that's passive trigger point as well as a fascial point. Tender in through there. You're fine, okay? So I can go right there. A lot of times that pathology is a little bit more down through here for distal IT band. So I can go in like that. If it's a little bit more of the lateral aspect of the knee, I can come in through there. I could do both of those, or kind of do a chain of needles through there. Okay, it's fine. My common peroneal. So I'm gonna find her fibular head, and I'm gonna go there's fibular head, okay. I'm gonna go 2 finger widths down, 2 finger widths in. Again, there's a little bit of like a depression in through there. That's gonna be common peroneal. It's also a fascial point, and continuing that lateral line. And then if I want to continue that fascial line between the 4th and the 5th metatarsals, and again, just in the web space there. So I have 75 millimeter needles. These needles look very similar to my 2-inch ones. They're just different lengths, okay? So be mindful of what you're actually using with that, okay? Look at the actual like number on the back. Yeah, it sounds like you don't have any questions. Okay. Not you, okay? Yeah. Yeah, no. All right, so we're gonna set this like here, okay? I'm pressing towards the center of the tube. I'm gonna tap in, right? Now, if I press from the top of the needle there, right, from the handle, like it's super wobbly. So I'm going to choke down on the shaft of the needle, and I'm gonna insert. Right, like up to 75%, right? Again, there's probably a little more than that, but if the handle would pop off, I can use my fingers and remove the needle. Okay? So easy breezy. I can do the same thing with glute med, right? And I put that needle in, and again, I'm moving with a purpose, right? It's not like, like get it in, right? And she's fine, it's not a big deal. Now, if you want to, as you're putting the needle in, right? I'm gonna do another one glute med here. As I'm putting the needle in, if I think like, hey, I want it to be like more comfortable for her, I can give her a little bit of like distraction technique, right? Or a little bit of like A beta love. I would just caution you with that. Like that's nice to do, just don't be creepy with it, okay? What's up, girl, right? It's weird, okay? So don't do that, okay? But yeah. Good with that. Come on. Let's move down the chain. And come. I don't know if I want 2 or 3 inch needle with that. Let's do 3 because that seems fun. Right? Seeing how much tissue I have to affect. And we go in through there. Okay. And there I bottom out on bone. Right. And so I want you guys to experience this because bone is like a very like hard end feel. right? You would think that bone would be painful just because like if you break a bone, it's painful. It's not, right? You might feel the little sensation of a tap. It feels weird, but like it doesn't hurt, right? But now I know my depth, right? And I go, okay. And I also say that bone always feels like is like a satisfying feeling, just because I'm like, no one ever gets that until like day 3. That like once we're up here in like thorax and I hit bone, I go, oh good, I'm not in lung. That makes me very happy. Okay, so, but you guys, and there's gonna be areas where like when you're putting a needle in and you're like, I think I got bone, and you're like, no, like you make sure you feel the hard end feel. It's a very distinct end feel with that. So there's bone. All right, coming down there, right? So I'm gonna use a 1-inch needle, right? So that's my 0.25 times 30 millimeter needle. That's probably good enough with that. And we go in through there. I can do the same thing, more of a distal IT band, more of like an insertional. Okay. We go there. I can do my common peroneal. So I found fibular head. I went 2 finger widths down, 2 finger widths in. Put that in, again, just in the area of my common peroneal. And then finally, I can gum down the bottom of the foot, or not the bottom of the foot, I can gum down to the foot, right? Sorry. I will say, so we're gonna use a 1/2-inch needle. There are 2 diameters of 1/2-inch needles. There's a 0.25 and there's a 0.18. So the 0.18 is a smaller diameter 1/2-inch needle. That's gonna be really nice for when we do like the hands and like the face, things like that, sensitive areas. I would also say that these ones look super fake out because that's a 1/2-inch needle and those are the 1-inch needles. So they look the same. It's just that with the 1/2-inch, you're only using half of the packaging. It's really annoying. Okay? So just make sure you're like paying attention to what length of needle that you're using. So this is a 1/2-inch needle. And we're just gonna come down like this into web space. And there we go. And then if she's like cool, you know, that's a pretty bony area.
Yeah, that's what I was wondering.
Yeah, so I could, if I go perpendicular at it, sometimes I just feel like I got like muscle or I just get skin and bone,
Okay.
right?
Yeah.
So I can angle like that.
Okay.
I tend to do that because I'm right-handed. But if you wanted to needle like this,
Yeah.
I could do that as well.
Okay.
Those are fine.
Okay.
Right? So once I'm pretty far away from precarious structures. But yeah, that's right, a local inflammation. And so once I remove these, to do anything afterwards that would be like anti-inflammatory doesn't make a lot of sense. Meaning if she's like, hey, can I do some sort of like ice pack, right? And you go, well, that's anti-inflammatory. So now find iliac crest, right? Which has already been found for me a little bit, but ooh, this is a good marker, so you're gonna have to scrub really hard today. I like that, okay? All right, so we're staying below iliac crest, right? So if I find sacrum, right, and I can draw sacrum and draw sacrum, okay, I like that. If I find greater trochanter, and let's go back and forth. She doesn't love when I do that, okay? She's like fighting me. So greater trochanter right here, okay? So if I find greater trochanter, right, I find sacrum there. And then from there, I'm gonna find midpoint, which I like about there, okay? And then from there, I'm gonna go like 1 finger width lateral to that. And that's gonna be piriformis. So you guys all saw how I did that. There. Like I said, I'm going to do quadratus femoris after this, just so we're not like exposing her entire butt. Okay? But there's piriformis. If I find greater trochanter, I come off of it medially or posteriorly or whatever direction that is, and then I can angle my needles like this. I'm going towards the back side of the femur there, right? And like I said, I'll just find greater trochanter and be like, all right, I'm gonna do one like that, and do one like that, and maybe do one there, and do one there. That's totally fine to do. Really with this, once we found our piriformis mark, anything lateral is fair game. I don't wanna go medial, right? I don't wanna go towards sciatic nerve, right? So if I wanna put ones through here and here and here, like that's fine to do.
Will you hit a bony backdrop or aim for one at all?
You might, if you have a long enough needle, you might hit the backside of the femur.
Yeah,
Yep.
cool.
Yep. So, with that inferior gluteal, that passive trigger point, that's the same place as the piriformis, so we already found that. With my superior cluneals, so they're coming over top of like the middle third of the iliac crest. So if I take my iliac crest and almost go like, there's a third, there's a third, there's a third, right? Kind of in through there, right? And then I can go just straight in. Again, glute med's coming out through there, so I'm also getting glute med. And I could bottom out on bone with that. Or I can angle my needle, and I'm gonna angle out towards greater trochanter. I'm going with the fibers of the nerve, right? The nerve fibers like that, as well as the tissue fibers of the glute med, glute min with that. But I'm always going to angle inferior lateral. I don't want to aim superior. We talked about that, right? I don't want to aim medial, right? I usually tell people not to aim towards the butthole, right? Which is just a good, like life thing. Right? Yeah. And it sounds crude, but you'll remember it, right? And so I'm gonna go piriformis, right? I'm gonna get some of my rotators, my superior cluneals. I'm gonna needle those, and then we're gonna come back to quadratus femoris. You guys good with me? Cool. So now for the piriformis, like I said, you're gonna need like a 4 or 5 inch needle, okay? So we have these 4-inch needles here, okay, so like 105, so about 4-inch needles. That's gonna be long enough for some people. It's not long enough for everyone. They do come in 5 and 6-inch needles, right? So, however, so with these are our Pro Max, they're our sport therapy needles. And when I first saw these, I was like, oh, what amazing marketing, right? Like, you're obviously an athlete, you definitely need the sport therapy ones, right? Like, please. Right? And so I was just like, okay, well, that's just marketing there. And the joke tells itself, right? These are a firm needle shaft, smooth insertion, longer lengths, right? Who doesn't love that, right? Really, these are a firmer shaft without being thicker necessarily. And so if you are trying to cut through denser tissue, whether it's muscle tissue or more scar tissue or whatever, they're not as flimsy, basically, without being like super thick. That kind of makes sense. Okay. So I'm going just perpendicular to the table with this. Okay. Got my little tab. I take that out. Okay. Again, I need to choke down on it. I can't push from here. Right? Choke down on the shaft. Insert the needle. And like you'll get to like at the end, like I feel there's some resistance. It's not bony resistance, but there's some resistance. And like what I find is like if you're hitting like piriformis now coming a different angle, and particularly if it's tight, right? Like they're like, oh, I can feel that, right? So you meet a different kind of layer of tissue. Like I said, I think I kind of got that at the end with you. For some people, I guess your 4-inch long needle is not going to be long enough to really get to piriformis. So that's that. If we come our deep rotators, I think of what I was doing. Okay, so I can come out here. I'm just going to go straight down towards like the back side of the femur here. Okay. Still using a 4-inch needle because why not? She's an athlete. Okay, proud of her for that. Okay. I could use a 3-inch needle too. I'm going to go here. I like that. Let's do a 3-inch one. Why not? While I'm at it. I can come a little more lateral. Again, I'm just making sure that I'm gonna like, not poke out the other side. Don't kabobber. Okay. But you guys get that idea. Then with my superior cluneals. So I can go just straight at it. Totally fine to do. Or if I want to angle my needle, get some more tissue fibers, kind of follow the path of those nerves, I can angle my needle inferior laterally, right, like that. Both of those are fine, just depending on what you want to do. We good with those? Mm-hmm. Okay, these are lots of fun. Okay, so let's take those out, and then we're gonna do quadratus femoris. Okay. Come take a picture of her butt. There you go. Just the top part. Just the top part of your butt. Oh, well, there you have it. That. And certainly if I wanted to get those deep rotators, I could have done that in this position as well, okay? But just, where did I put them? If I go, ischial tuberosity, and I find that, and then I found, again, greater trochanter. I can test myself again. She doesn't love when I do that, okay? Go greater trochanter, okay? And then from there, I'm gonna go about midpoint, okay? So I find that, again, sciatic nerve is gonna be kind of coming through like this. So I wanna make sure that I'm a lateral to that. And as long as once I found kind of that midpoint, I can go anywhere lateral to it, okay? And with this one, my needle angle is going to be kind of perpendicular to the tissue so that there's going to be a little bit of a superior angle. I'm not aiming like that, but like it's mostly anterior, a little bit of a superior. You know what I mean? Just because I'm perpendicular to the tissue. Okay. Got it. Let's get to these. That. I'm using a 4-inch needle because I probably need at least 3 inches of the needle. Okay. And there we go. Again, I can keep coming out laterally if I'd like. Okay. And if I'm more lateral, I'm more likely to hit bone. Okay. Sound good? All right, so let's find inguinal ligament. That's gonna be kind of right where the shorts are here. Okay. So we can find inguinal ligament. Okay. Like I said, I can feel that. That's a ropey ligament there. Okay. All right, so then we're going to find sartorius. So we're going to bring her leg like this, and then like that, go ahead and muscle test with that. I can feel sartorius, so I'm gonna grab it there, okay? Bring her leg back down, and I have where that is, so kind of right in there, okay? So I had her drag heel up the opposite leg, muscle test, feel that tendon pop out, right? I just kind of grab a hold of it and then let the leg come down. Because otherwise, if I draw it when she's in the figure 4 position, then my drawing is going to move. All right. For my adductor longus, right? So it's going to be kind of right in here. Go ahead and muscle test into adduction. So bring your leg in, right? I can feel that right in through there. So I'm going to draw out the lateral border of that. I drew on your shorts, sorry. You're fine, yeah. And so sometimes my triangle looks good and sometimes it looks like whatever that is, okay? Doesn't matter, I found my borders, okay? So I've got sartorius, I've got adductor longus. Let's see if we can find a pulse up in here. Oh, you've got a good one, good job, thank you, okay. So right in there, I can feel a pulse. So I'm just gonna mark that out like that. Okay. So from here, I find sartorius. I'm gonna go medial to that, so I'm inside triangle, but I'm lateral to femoral artery. You think, hey, I think that's like iliopsoas there. Go ahead and bring your leg up, right? Oh, look at that, okay? That's a nice straight leg raise, iliopsoas. Okay. I can go just straight down in. For pectineus, I find adductor longus. I go lateral to that, but I'm medial to femoral artery. That's gonna be pectineus. And then from there, right, I already found adductor longus, so I can go up in like that, right? I can do another one there. I can get a little bit more like Magnus, right? And I can work my way down like gracilis if I want, right? I can get as proximal as they'll allow me, right? If I've got like a proximal groin strain, that's fine. And so like I said, as I start getting farther away, like if I put the one there and you want to put one there, fine, I don't care. Right? I'm just being more specific up here because I'm near precarious structures. Okay. You good with that? Okay. All right. Got sartorius. I went medial to that, but I'm lateral to femoral artery. Again, I'm just going straight in. I've got a 3-inch needle here. And she likes that one. You can tell. Okay. That was fun. Okay. All right. We go adductor longus, I go lateral to that, but I'm medial to femoral artery, that's pectineus. And I'm gonna go straight in for that. Right. Oh, you were better with that one. Maybe not. Okay, you're just less expressive. Okay. All right. You're like, I'm just internalizing things now. Okay. As I come out to adductor longus, again, I can aim like that, or I can aim straight down. I don't care, whichever makes you happy. Okay. We're gonna go like this. And then I can keep working down the leg. Right. I've got 3-inch needles here. And I'll just do one more because I already made the circle, so I wouldn't want to leave that one out. Yeah, you're like, I'm fine, whatever. Yeah. And voila. Okay. Not terrible, right?
I might jump.
That's fine. We'll just judge you, it's fine.
That's okay.
Okay. All right. So first off, if we find vastus medialis, vastus lateralis, go ahead and make a muscle for me. Okay, good job. So we can do medialis, we can do lateralis. Fantastic. Okay. Yay. If I'm going to do 4 corners, okay, so I'm gonna palpate and I'm gonna find. See, there's medial epicondyle. I can feel there. I can feel tibia right there. If I go on the lateral side, there's her fibular head, kind of right underneath that. And then I can come onto lateral epicondyle. Okay. Cool. And there we go. Can I have some finger cots behind? I think there's a box.
I might jump.
That's fine. We'll just judge you, it's fine.
That's okay.
Okay. All right. So first off, if we find vastus medialis, vastus lateralis, go ahead and make a muscle for me. Okay, good job. So we can do medialis, we can do lateralis. Fantastic. Okay. Yay. If I'm going to do 4 corners, okay, so I'm gonna palpate and I'm gonna find. See, there's medial epicondyle. I can feel there. I can feel tibia right there. If I go on the lateral side, there's her fibular head, kind of right underneath that. And then I can come onto lateral epicondyle. Okay. Cool. And there we go. Can I have some finger cots behind? I think there's a box. Let's see. Okay, there's fibular head. There's tibia. There's medial epicondyle, lateral epicondyle up in here. Okay. Vastus medialis, vastus lateralis. I like that. Let's see. Okay, there's fibular head. There's tibia. There's medial epicondyle, lateral epicondyle up in here. Okay. Vastus medialis, vastus lateralis. I like that. So for vastus medialis, and we can do vastus lateralis. Okay, that was a little twitchy. Okay. And so from there, if I wanted to do a little stim, okay, I'll show you how this one works first. Okay. So I'm going to turn this on. This is on 1. Okay. So I do metal to metal, metal to metal, and then I'm pushing the blue button. Okay. Get anything there? No, not really. Turn that up a little bit. Oh, there you go. That's cute. Okay. And so certainly, like, I'm getting more like vastus lateralis right now. Okay. She might be able to handle more stim. Nope. Okay, she doesn't. Okay.
I mean, I could.
Yeah. So if I'm like, hey, I'm getting like a lot of vastus lateralis, right? Like, I don't have to do just those 2 needles. I could do like 2 in vastus lateralis and 2 in vastus medialis, right? And then I would attach her to alligator clips.
Lindsay,
Right?
can I ask you a question?
Yeah.
For that one, so it's the tip of where you put it on the needle is the only one that's going to twitch?
So for vastus medialis. And we can do vastus lateralis. Okay, that was a little twitchy. And so from there, if I wanted to do a little stim, I'll show you how this one works first. Okay. So I'm going to turn this on. This is on 1. Okay. So I do metal to metal, metal to metal, and then I'm pushing the blue button. Okay. Get anything there? Yeah, not really. Turn that up a little bit. Oh, there you go. That's cute. Okay. And so certainly, like, I'm getting more like vastus lateralis right now. Okay. She might be able to handle more stim. Nope. Okay, she doesn't. Okay.
I mean, I could. But
Yeah.
I don't want to.
So if I'm like, hey, I'm getting like a lot of vastus lateralis, right? Like, I don't have to do just those 2 needles. I could do like 2 in vastus lateralis and 2 in vastus medialis, right? And then I would attach her to alligator clips,
Lindsay,
right?
can I ask you a question?
Yeah.
For that one, so it's the tip of where you put it on the needle is the only one that's gonna twitch?
Like the lateralis is just really a lot happier, yeah. So, but no, it should do it equally. And I don't have to do both of them. Like she could hold one, right, and ground it, and I could do just the other.
Okay.
And so that's how that works.
And it's feeling a little aching. Like I'm feeling it like coming up here now.
So, but I could, right, do a chain, do 2 more needles. Lucky for you. Okay. She likes that one. Okay.
There goes your nap.
I wouldn't go very tight with the other ones.
Okay, there you go.
So these are all 50.
Yeah, these are all 2 inchers. Yep.
I told you I was a jumper.
Yep.
I'm starting to sweat.
Yep.
I usually
good.
don't pass out.
Yeah,
I
good.
just sweat.
Okay. That's fine. I sweat too. Okay. All right.
Nice pack we have.
There you go.
No, I'm good.
Yep,
Thank
she's
you.
fine.
Oh, this 9. It feels like it's like a gerbil. Like, oh.
Like the lateralis is just really a lot happier, yeah. So, but no, it should do it equally. And I don't have to do both of them. Like she could hold one, right, and ground it, and I could do just the other.
Okay.
And so that's how that works.
And it's feeling a little aching. Like I'm feeling it like coming up here now.
So, but I could, right, do a chain, do 2 more needles. Lucky for you. Okay. She likes that one. Okay.
There goes your nap.
I wouldn't go very tight with the other ones.
Okay, there you go.
So these are all 50.
Yeah, these are all 2 inchers. Yep.
I told you I was a jumper.
Yep.
I'm starting to sweat.
Yep.
I usually
good.
don't pass out.
Yeah,
I
good.
just sweat.
Okay. That's fine. I sweat too. Okay. All right.
Nice pack we have.
There you go.
No, I'm good.
Yep,
Thank
she's
you.
fine.
Oh, this 9. It feels like it's like a gerbil. Like, oh.
See, I'm gonna clip this. I'm gonna clip it close to the skin just so it's not like pulling on the needle a lot. And then I'm gonna do the same thing. And I'm doing 1 chain on medialis and 1 chain on lateralis just because I don't really want just her lateralis being felt and not medialis. So like, let's just do one and then the other. Makes sense to me. So when I turn this up, right, I want it to be noticeable but comfortable. That's kind of what I tell her. Right? So, and you can do 1 chain and then the other. I'll usually tend to turn up both at the same time, but it doesn't really matter to me, okay? So I want it to be noticeable but comfortable, okay?
No, too much, too much. Still too much.
We're going down. So, see, I'm gonna clip this. I'm gonna clip it close to the skin just so it's not like pulling on the needle a lot. And then I'm gonna do the same thing. And I'm doing 1 chain on medialis and 1 chain on lateralis just because I don't really want just her lateralis being felt and not medialis. So like, let's just do one and then the other. Makes sense to me. So when I turn this up, right, I want it to be noticeable but comfortable. That's kind of what I tell her. Right? So, and you can do one chain and then the other. I'll usually tend to turn up both at the same time, but it doesn't really matter to me. Okay. So I want it to be noticeable but comfortable. Okay.
No, too much, too much. Still too much.
We're going down. So you might like mess with it a little bit. But sound good? Okay. So we can do that. Turn that off. So you might like mess with it a little bit. But sound good? Okay. So we can do that. Turn that off. We're not necessarily going to practice it in lab. I feel confident that you guys know where Rec Fem is. Okay, but like, good job. Okay, but like I certainly could. All right. Like I said, it's not that like areas that we don't do in lab, it's not that we can't do them. It's just more I'm like, I think you guys know where that is. We're not necessarily going to practice it in lab. I feel confident that you guys know where Rec Fem is. Okay, but like, good job. Okay, but like I certainly could. All right. Like I said, it's not that like areas that we don't do in lab, it's not that we can't do them. It's just more I'm like, I think you guys know where that is. So I want to make sure I'm bottoming out on bone. I've got 1-inch needles here. So there's medial epicondyle, sorry. And I got bone right there, okay? And so like she's jumpy, right? But like you saw this one here that she was like, oh my gosh, right? And so I like kind of left it there. And then whether she knew it or not, I revisited it and I put it in a little more, right? So yeah. But same thing here. I'm gonna go a little bit more of an angle just so I get a little bit more tissue purchase. She liked that one too, okay? Gonna remember that she volunteered. Just saying, just throwing that out there, okay?
I just want to show you guys.
Yeah. These are the patients we hate. No, I'm just kidding. All right.
Okay.
I know, I'm teasing you, okay? Lateral, okay. We got one more.
I would have seen the first acupuncture session I was on, like literally crying all day. I could not. I was like, this isn't normal. And he's like, it'll get better.
So for fibular head, like I don't usually go just straight at it just because I get skin and bone, right? So I don't usually go just straight at it. I will usually do an angle just so I get more tissue purchase. It doesn't matter your angle. I don't care. Like I said, my angle is usually based on the fact that I'm right-handed. But to be honest. Just like that. And then I can do the same thing, right? She loves the stem, so she's really excited about this.
I've actually never felt.
So I want to make sure I'm bottoming out on bone. I've got 1-inch needles here. So there's medial epicondyle, sorry. And I got bone right there, okay? And so like she's jumpy, right? But like you saw this one here that she was like, oh my gosh, right? And so I like kind of left it there. And then whether she knew it or not, I revisited it and I put it in a little more, right? So yeah. But same thing here. I'm gonna go a little bit more of an angle just so I get a little bit more tissue purchase. She liked that one too, okay? Gonna remember that she volunteered. Just saying, just throwing that out there, okay?
I just want to show you guys.
Yeah. These are the patients we hate. No, I'm just kidding. All right.
Okay.
I know, I'm teasing you, okay? Lateral, okay. We got one more.
I would have seen the first acupuncture session I was on, like literally crying all day. I could not. I was like, this isn't normal. And he's like, it'll get better.
So for fibular head, like I don't usually go just straight at it just because I get skin and bone, right? So I don't usually go just straight at it. I will usually do an angle just so I get more tissue purchase. It doesn't matter your angle. I don't care. Like I said, my angle is usually based on the fact that I'm right-handed. But to be honest. Like that. And then I can do the same thing, right? She loves the stem, so she's really excited about this.
I've actually never felt.
You do this a lot on your older golfers.
Mm-hmm.
This is
They actually love this.
This is the.
People usually get up and they're like, my knee feels really like a lot looser. It doesn't feel as stiff, which is again kind of a nice feeling if you've used to a stiff arthritic knee. All right, so this one, you're not going to see probably muscle contraction because we're not in muscle. It's gonna be, so I'm not necessarily looking for anything, I'm just based on her feedback, right? So again, I want it to be noticeable but comfortable. Like that. I had another needle here, another needle here, another needle here. Like, even if the clips are just there, all of those needles are going to be stemmed to some extent because it's all metal in you. So, makes sense. Cool. Yeah. I had another needle here, another needle here, another needle here. Like, even if the clips are just there, all of those needles are going to be stemmed to some extent because it's all metal in you. So, makes sense. Cool. Yeah. Number, so an hour and 16 loser. He's really fast. So it's like 5. So we've got quad tendon there. Right? We've got patellar tendon there. So I can go quad tendon, I can go right in. Okay. Patellar tendon, I can go right in. Okay. I could go underneath it. Okay, we can do that. If I want to be even more aggressive, I can like thread it down the patellar tendon. That sounds fun. Okay. Yeah. All right. There's patella. Right. So I can aim my needles to like go underneath patella. Okay. So getting in that connective tissue. I can go right at tibial tuberosity, right? So we'll do some of those. So I'm gonna do those first and then I'll come back and do MCL, LCL. So you guys see that. Let's see. There's some of those. And that's a quad tendon. Right, again, I meet some resistance with that. It's not bony resistance, but I expect that with thicker connective tissue. Again, patellar tendon, I can go just straight into it. That's fine. Okay. I can also go a little bit more of a thread. Okay. That was fun. Okay. I can go underneath it. Okay. So let's aim. Like
Are you using 1 inch?
Those are 1 inchers, yep. And same thing here. Like that. Okay. So you guys see those? Okay. If I wanted, if she had like a Oshkosh or something like that.
That would be like a pain relief for them?
Yep, so pain relief. So like there's tibial tuberosity. I can go just straight at it. I'm just gonna get skin and bone. So I feel like for me, that's not terribly effective. I just want more tissue with it. So I'm going to do some, like a pretty shallow angle here. So that I'm getting at it. I can even go like right over top of it with a pretty shallow angle. Right, it's just so I get more tissue purchase. So I can go like at it like that. I can go at it like that. Right. So again, just I feel like going perpendicular to it. It like gets in like a little bit, and the needle's like meh. So that's me. That's for tibial tuberosity. And like certainly if someone has like pain there or patellar tendon like pain, like I will follow up that entire chain. Like a lot of times there's tightness kind of throughout that whole chain there, and then it's just getting pulled from like right there. So like do patellar tendon, do quad tendon, like work up the quad with that. Just because I find a lot of times like there's some dysfunction up in here, but the pull's coming there, so they're feeling symptoms distally.
I wanted to share just right on here, Lindsay. So I actually have an acute partial tear of the plot tendon right now that I'm treating, and this guy was pretty swollen coming in, needled. It got even more swollen right after the session, which is to be expected. I was like, listen, you're gonna be sore, and he was for 2 days, and then it started feeling better. And so a week after, the swelling has gone down, and we're able to do more functionally.
Yep.
So sometimes you'll get a little bit more of that inflammatory response, but it works.
Yep. So we've got, so I can go around patella, right? So you guys get that idea. Okay, I could do more than that. I'm just kind of aiming underneath the patella. Those are 1/2-inch needles. So again, I'm not like the underside of the patella there. I'm just in the connective tissue around it.
Quick question, just while I'm on this patient. If you have someone that has subcutaneous, like visible swelling, either like suprapatellar or infrapatellar, like what are your thoughts on that in terms of like what you've seen or you've treated it? Like go right on it, go like around? Like,
So swelling we can actually treat. We talk about this more in the advanced class, but swelling in and of itself, like there's kind of a protocol, if you will, of 30 for 30, which there's nothing magic about them or 30. But basically, I would, if her medial knee is swollen, I flood the knee with 1/2-inch needles, like flood it. Or if it's like when they get their ankle, like
like 30 needles?
30 needles, and then elevate it 30 minutes. So that's the 30 for 30. But there's no magic about 30, right? So if you do 25, it's fine, right? It can be 25 for 30. It can be 40 for 30, right? Ice, right? So I might do Normatec. I use fireflies a lot. I'll do, you know, compression, things like that, but I'm not going to do ice.
Fireflies?
Yeah, do you know what the firefly thing is?
I don't know what
It's basically, it goes, I get nothing for this, I just really like them. It's basically like a little like stim unit for your common peroneal. And it forces your foot to do that. And so it's stimulating your nerve without fatiguing the muscle. It does the same thing as like a Normatec, but because it's an active movement, it takes about half the time, and it's mobile. You can just stick it on, you can wear it.
Do you just use it for the peroneal nerve or anywhere?
Well, that's because it's pretty superficial there. They haven't done research on upper extremity, but I know a number of the people work in baseball have it on radial nerve.
Yeah.
But yeah, so I want the leg relaxed, right? If I'm just doing MCL or LCL, I can bolster them if I want, because I'm in non-contractile tissue. But do not do a patellar tendon in this position, okay? Like that. But no, I'm fine. You're small enough that I can find your MCL just fine, or LCL, but some people I'm like, where am I going? So if we go there, right, and there's your tibia, right, and so I'll go at the origin, I'll go at the insertion, and then I can fill in between, right, for MCL. And I can do the same thing laterally, right? I find fibular heads right there, I find femur, and then again, filling it in between. Okay, for MCL, LCL. So if I go at the MCL, so I can do a couple things with this. All right. This is a 1-inch needle. Going like that. And then I can go at the insertion. And then as I fill in between, these are just 1/2-inchers. I could use 1-inchers, but I'm just being lazy and not getting them. I can either go straight at it, like that, or if I want to kind of like thread across the ligament, I can do that. I could aim that way. Again, I just aim that way because I'm right-handed, right? But I could do that. So I can do both of those. I could do a line of needles here and a line of needles there. I could do multiple needles there. I mean, it's a decently broad ligament. Okay.
As long as you're staying away from the joint line.
Yeah, and with the knee straight, you're probably it's gonna be hard to get into joint line anyway.
Yeah.
If you would have the knee bent a little bit more, I'm just staying away from joint line. Yeah. But yeah, with the knee straight, it's pretty hard to get in. But yes, and then I can again do the same thing laterally. So, good with that?
Can you do both sides at one time?
Can I do MCL and LCL? Yeah. yeah, if the person just has at that point, we're like, maybe we need a surgery.
Yeah.
Tuberosity, okay, so I'm gonna poke right in there. Whoops, maybe I won't. So I've got ischial tuberosity, okay. And so again, I can go right at it, that's fine. I usually drop right below it and then aim like this, right? And so mostly an anterior angle. And what I'll usually do is I'll do one kind of like that. And then I'll do one where I start a little more medial and aim a little lateral. And then I'll start one where I'm like a little more lateral. I'm aiming a little medial. I'm not like aiming like that. It's mostly an anterior. Right? I just make a little smile on his butt. Super cute. Okay? Sweet. If I want to mock up that he's got some sort of like hamstring strain, right? Is that where it started? Oh, poor thing. I'm so sorry for you. Okay, and that's where it ended. And then I can fill in between. Okay, great. For hamstring musculotendinous junction, right? So I'm gonna bring, I got ropey tendon, ropey tendon, ropey tendon. You might have a bigger sister there. Okay, sweet. Yeah, I'm just telling you, you might.
I think I have them both legs.
Okay, sweet.
I don't know.
Yeah. I had an MRI on my knee once, it was years ago, and it showed that I had like a ruptured Baker cyst. I was like, Doc,
I've
like
got
we
this
need to
knee.
talk about that.
I've got this knee MRI and I had surgery on it, but
Oh, yeah.
that's been there since I was in high school, so
Yeah.
I don't know what it is.
Interesting. Yeah, okay. Yeah. So musculotendinous junction of the hamstring. So I just found ropey tendon. I started to work my way up with that. Medial and lateral gastroc, right? So again, usually there's some good spots in there. Right? Going through there. I can come down soleus, right? Come more like that. Go more lateral soleus. Sural point, so I'm gonna find Achilles, kind of work up musculotendinous junction there. That's gonna be my sural point. I can come into Achilles. Again, a lot of times that pathology is kind of right in there. I tend to avoid this kind of like ropey Achilles. You can go through it. I usually kind of go underneath it. I have a lady right now I see who she had like an Achilles repair years ago. That thing is still very thick and immobile. And so I will needle that. But it's one where it's like, I mean, it's so thick that like when I start winding, I actually am afraid sometimes that the handle's gonna pop off. Like it's just so, yeah. So, and she's like, whatever. And I'm like, okay. I can go at the heel right there if it's more of an insertional issue. Okay. And then I can go at the bottom of the foot. Okay. And then is that where most of your pain is?
No, that's all in the arch.
All in your arch. Ooh, that's going to be even more fun. Okay, sweet. He has plantar fasciitis. I only need 3 inchers, but honestly, these are going to look way cooler sticking out of your butt, so I'm going to use 4 inchers. Okay? Just letting you know. Okay. Okay, start like that. Okay. And oh, you got more meat than I thought. Good for you. Okay. Good for you. Proud of you. Okay. Ooh, hello. You like that one? You all right?
Mm-hmm.
Okay. You
Mhm.
sure?
Yep.
Okay. Yeah, he likes that more, I can tell. Okay.
And if he said he was not alright.
Yeah, then I'd move it. Yeah,
Just
and then
take it back out.
Yeah. The goal is not to torture him, right? But I will say that, like, as you guys are doing this, like, I don't need subjective feedback on every single needle, right? How was that? Tell me about it. Tell me all the words, all the adjectives. Like, I don't care, right? Because, like, if he goes, oh, that one was ouchier, all right. Is it gonna change what I'm gonna do, right? Now, if he's like, ah, right? He clenched, right? I let him relax. And I go, you good? We continue. If he's like, oh my God, that one is killing me, then take it out, right? Sometimes you're just near like a hot cutaneous nerve, move it over a centimeter and it's totally fine. Right? But like the goal is not to try to put them in more pain. I'm mean, but I'm not that mean. All right, and then that one was fine, okay? Good?
Mm-hmm.
Alright, sweet. That's for hamstring. Let's go. His hamstring strain. Sorry about you here. He likes that one too, right? Like he's good, right? Some of them are a little jumpy. Dylan never wanted to fingerless. You okay? Okay. You look relaxed.
Yeah.
Okay. Look at that. Sorry, I didn't mean to scratch you. I was gonna do that. Okay. All right. Let's do musculotendinous junction of the hamstrings. 2 inches here. Yeah, that, I don't know what that is, so I'm not going to go through it, right?
Is it on the other side too?
What's that?
Is it on the other leg too?
Yeah, yeah. So it just, this one feels like maybe a little harder, but I don't know. Yeah, a guy come in and he has like a huge, like just ball right on his ankle, like that. Like, and he was like, what do you think it is? I was like, I don't know. I was like, it's either a cyst or you like ruptured your peroneus brevis and like, you know, I don't know, right? But he's like, can you needle it? And I was like, no, I don't. I pull out my anatomy nutter book like all the time and I show people and I go, listen, here's the structures that are here. This is what it could be. Other than that, I don't know, right? I don't have all the answers, so. Or you just have a tumor. I don't know. That'll be bad. Okay, there's gastroc. There's some soleus. Alright. There's another soleus. Let's see. What I need. Do my serral. Again, that's another one. Don't go for gold. You will get tibial nerve. Right? I'm just getting in the area of. Let's do his Achilles. Like that. Yeah, that I know. Like I said, that one usually feels pretty darn good. I'm lying. Yeah. Let's go. We can go like underneath Achilles. Alright. And do one more there, like going underneath Achilles.
Do you ever dart down the sides of the Achilles, like medially and laterally?
Yep.
Okay.
Yep, so like that's kind of what I did, and then I could keep doing that.
Okay.
And then if it was like super thick, right, like I can do a couple like, you know, winding with that, right? And then almost kind of move it there and try to like loosen it up. He likes that a lot, I'm sure. Okay, yeah. Okay. We could do that with the Achilles too. He'll like that, right? And then you see as I try to like move it, do you see how it's kind of like pulling the tissue up? So again, it's just trying to loosen that up a little bit. I can piston it too. He'll like me when I do that, but whatever. Okay. So for the bottom of the foot, right? So a couple things. One, like I said, once the needle is in, it's a non-event. So just get it in there. Don't like, you know, do the tap and then be like, let's talk about the tap for a bit and then push it in more. Just get the dang thing in, right? I also find that like, I kind of do this anyways. Sometimes the actual like tap is a little shocking, right? So if you almost see like what I do is I just kind of push. It's less of a tap, okay? With that. So we're just gonna get it in. Okay? So I am gonna do, let's see, so your pain's kind of more arch. Woo! Oops, someone died. So I'm gonna go there and then like this type of arch or this type of arch? But all right, sweet. Okay. Yep, you like that? Okay, that's it. The arch feels less amazing. I know that's shocking. Okay. Oh, you're gonna be sweaty.
Sorry.
I know, I'm just teasing you, I don't care. Okay. I know, I'm sorry. I actually feel bad. Rarely do I actually feel bad for other people, but it's a nice thing for me to say. But when the first time someone comes in to see me and like it's plantar fasciitis, and I'm like, oh man, I'm sorry. I just want you to like me, and it's not gonna be. Yeah.
Oh.
I know. I'm sorry. Okay. Mm-hmm.
And you're not going to like something like that, rope your tendons in the bottom of the foot more like.
No,
just
I mean
like
I could. I'm just kind of following his pain a little bit more. I mean, I can. Does it come up towards the toe too?
Sure, if you want to, why not? You're already there.
Yeah. Do we give me a couple more of just that box right there? Sort of the yellow sticker, as opposed to the thicker diameter ones, just because I'm being really nice to him. This is one of those things, right? Like, he has pain, so he's like, yes, do this to me. Most people, if they don't have pain, they're probably like, please don't stick a needle in the bottom of my foot, right? But for him, he's already like, he's in pain. So I know, I'm sorry.
Now, Lindsay, that study that they compared like the thicker needle that got
Yep.
longer results, but they didn't want to do it again.
Yep.
Obviously, would a thicker needle diminish the number of times I have to do this to him?
Maybe.
Okay.
Maybe. I mean, it just that like, good job, or maybe, I don't know. So yeah.
But using the normal ones we've been using everywhere else would be fine.
Yep. We good with this? I'm gonna let him, because he has pain, so I will definitely do 100 hertz on this. Okay. So that sounds terrible. Order of his tibia here. I'm gonna draw that out. And so my needle angle is like back up towards me, right? So it's kind of anterior lateral with that, right? Again, I can go just like at it like that, but I'm really trying to get more of where like the tissue is connecting into the bone there, right? Sorry. And I'm just gonna use like 1-inch needles, bottom out on bone. Okay, so that's for MTSS. For anterior tib, go ahead and dorsiflex for me. Good, we've got that. You can relax. So anterior tib. For common peroneal, so I find fibular head, I go 2 finger widths down, 2 finger widths in for common peroneal. For my saphenous, so I find tibia. As the tibia starts to go vertical right there, I come back into there. That's going to be my saphenous. For my tibial, I find his medial malleolus, and I'm going to do about 3. If I put my pinky there, that's 4, but about 3 from the top of it. Finger width proximal to medial malleolus. And I come in right in here. All right. With that, let's do deltoid ligament, right, like in through there. For my lateral side, so ATFL, right, I can go kind of in through there. Calcaneofibular ligament, right, I can go more posterior. If I'm just doing his lateral ankle, I'm probably putting him in sideline, and I'm probably working up the like rest of the lateral leg too. Okay, so with that. For towel curl, so with that, I tend to avoid like ropey tendons, and I'll go like, there's space there, I'm gonna put one there, and there's a space there, I'm gonna put one there, space there, I'm gonna put one there. Okay? So just going into the joint space. Let's see, for deep peroneal, between first and second, it could also be where neuroma is. And then for first MTP, right, so there's joint line, I can feel that right in through there, all right. Kind of in through that. His space isn't that big, but I get the idea. And then from there, right, like this is fair game, right? So if you think it's like, hey, it's a second toe or a third toe like issue, I can put needles in those, right? Like I said, I found some things like needles work well for, and some things don't. I had a girl who had like sesamoiditis, and we tried needling that. She didn't like me very much. That hurt, and like the only thing that worked was booting her. Turns out, you know what I mean? Like we just needed to unload her. So again, if you think like maybe something in like, you know, midfoot, I can try. So, like I said, needling can be very helpful, but it's not a cure-all for everything. Okay. Success, right? So again, here's kind of my angle, right? It's a little bit more of an anterior angle. and I bottom out on bone like that. Right? So I'm gonna see that angle. Okay? So again, it's not going straight down at it. It's kind of coming up towards the underside a little bit more. Right? But it's only a 1-inch needle, so it's not like I'm getting like really the underside of the tibia. I'll do one more and you'll get the idea. And then what I would do for him, right, is, you know, I'd obviously find like where it's symptomatic, put needles, and then I could put, you know, more needles through here, attach stim on either end of that, and then just like run periosteopecking stim. Okay, and then obviously all of them are gonna get stimmed to some extent. So I'd put one on either end.
You do that probably like 2 hertz to start.
2 hertz, yep. Yep, and I'm just getting that pecking, so. There's that. Let's see. Anterior tib. There's enough tissue there for a 2-inch needle. I usually find that one spicy, me personally. Common peroneal. Good? Yeah. Saphenous. Ooh. That's another one that's angry on me always. I don't know. Let's see, tibial. Tibial is one that can get a little nervy. So again, I don't go for gold on this one. Right, so I'm using a 1-inch needle, but like only using about half of it. Okay. Like that. Let's see what else. I need deltoid ligament. You guys can move yourself if you need to. So you can see, so I can go just straight at it. That's what I'm doing. I could also angle it a little bit more. I just want to get more tissue purchase. Sorry, that one gave me a pokey one.
It's not as bad as the foot.
Fair enough. Yeah. Let's go. Towel curl. So I'm just going into joint space there. When I was teaching, this was maybe 2 years ago, I was in Birmingham, and the guy who was the model for, or my demo for like posterior chain, he was kind of a funny guy anyway. And when I got to the bottom of the foot, when I put that needle in, he screamed, I did 9/11, I killed JFK, I did all of that. And I go, oh my God, like he was admitting to torture.
Oh.
But I was like, I cannot believe you just screamed, I did 9/11. Like I was on the floor. Never forget that. I like had to stop class. I was like, I'm not well right now. I'm laughing so hard. All right. This is towel curl. Oh, hello. We like that one. Okay, good stuff. Let's go. Ankle ligament there. Alright. Just because of where these are, like I could do calcaneal posterior. I'm just not doing them because the needle's gonna be real weird. Okay. But we get that idea. Deep peroneal. That is a 1-inch needle. That is a 1/2-inch needle. Hello. Hello. And typically what I do for the toe is I'm going to take a super shallow angle and I'm just going to go across the joint like that. I know that doesn't feel good, I'm sorry. That's what I typically do. Okay, and I could do several more like that. Right? Or if they have like an angry bunion, I could do several of those. I could certainly, with any of these, come more on the plantar side. We just all learned that that's not as pleasant. Okay. But again, if they're annoying,